properly?
Yeah, I can hear you.
Okay, perfect. So, thank you guys all for coming. We have Amber or Dr. Gordon, a PGY3 at University of Arizona, and she's here to talk to you guys about audition rotations, just how to kind of thrive as your fourth year, and have like a bit of a Q&A at the end. So if you have questions, please send it in the chat or um, you know, try to ask as you can. But yeah, hope you guys enjoy. This is recorded and we will share the link with y'all afterward. But yeah, no, thank you, Amber.
Yeah, no, of course. So I'm Amber, refer to me as Amber, Dr. Gordon, whatever, but prefer Amber. Just a little bit about my background, about where I came from and where I went to med school and stuff like that. So originally I'm from Boston, went out to Arizona State, and then didn't get into medical school. So I did a post-bac program at LECOM, which is a DO school. They have like four of them now. It's like massive. And then I went to LECOM Bradenton in Florida for med school, and then ended up matching at University of Arizona in Tucson. And now I'm a third year, an upcoming fourth year, and I'm going into trauma. So this really is for you guys. So please ask whatever questions you have. There's no stupid questions. That you guys are just about to start a journey where I was saying before, like it's so exciting, but it is just like mentally and physically exhausting. And the expectations of you guys on orthopedic rotations is nearly almost impossible, right? Like you show up, you can do everything right. And if you make like one little thing, you're gonna go home and be like, God damn it. Is that like, why did I do that thing? And 9 out of 10 times, no one even noticed, but it will keep you up at night. And you probably won't be sleeping much anyways, because ortho rotations are very long and exhausting, but also like so fun, way more fun than any other specialty you guys have done so far. I will assure you. I was like walking in the hallway today and I was rounding and I saw my, 10 patients in, I don't know, 20 minutes. And when I came out of my last patient, I saw medicine on their like second room down. And I was like, oh my God. So you guys can do this. It's way more fun. Okay. I'm going to share my screen again. Like, feel free to interrupt me. Like, really, this is for you guys. Um, ask questions in the chat. I believe that Rachel is going to help me. If you put something in the chat, she's going to interrupt me and ask the question, or feel free to speak up. Like, this is really, like I said, for you. I'm here for you guys, everyone. Let me see if I can figure out how to share my screen, desktop. All right. Zoom world. Can you see my screen? Okay. Woohoo! Thumbs up. I like the thumbs up. Okay. I'm going to put in presenter mode. So again, I'm Amber. I'm PGY3. Okay. So a lot of this will seem somewhat obvious, but I promise you now that I'm going into my fourth year that it clearly is not obvious, because I even give a similar lecture to the students that rotate at my institution, to every single one of them, and then they still don't do things. I'm like, I specifically told you to do these things and you still didn't do it. So like, it's clearly not as obvious. So don't be like, oh, you know, it will just put you like so much more advanced, like the simple things that you're like, I'm not really sure. Like, how early do I get there? Like, how late do I stay? Like, we'll go over all those like little details that like you're really not sure about. But in terms, general advice as an orthopedic resident, especially if you want to work well with orthopedic residents, they're busy, they're tired. Do not ever complain about being tired. Stay humble no matter what. Like, no one cares what you got on the highest score that you got on STEP, or if they even have scores anymore. No one cares about that. They want to know, can you work with us and can you help us? So if you can do that, especially most of this is from like my experience being a resident and having medical students and being a medical student at the places I rotated at, was like, if you can get along with the residents, like that's your first like way in the door. If the residents don't like you, chances are you probably may not even get an interview. So work hard, stay humble, be the first one there. Like, I'm telling you, be there so that people think you like stayed overnight. And never just like leave. I don't know how, but sometimes it just happens and we'll be like, where's the medical student? And they're gone. So like wait for someone to physically tell you you need to go home. You've been here for however many hours. You're gonna make mistakes. I do every day. And the biggest thing is that you need to own up to them. Like if someone tells you, oh, hey, go do this splint or go get this or whatever they're telling you to do, and then you realized afterwards that you did something wrong, like you put the wrong splint on the wrong patient, or you laugh, but this is all real possible things. Just be like, hey, I did this thing. It needs to be fixed. Because if we don't know about it, we can't fix it. As residents, if I'm with a medical student, like I will have your back no matter what. If I'm telling you to do something and you go and do it and you do it wrong, that's like up to me to fix that mistake, but I can't fix it and I can't help you if you don't tell me. Team sport, most people going into ortho have either played on a team or interested in sports. And if not, like you've done something around, but like be a team player, like work with other medical students. Don't gun anyone down. Do not do it as much as you want to. And as much as like you're stressed and you're tired and you're like, I just want to show everyone how good I am because I am good and I worked so hard. I promise you that we will notice, even if you're being a team player with other people. Um, okay, those two are quick to read the room and adapt. So anticipation is a big thing. Anticipate what's next. If we'll get to this, but don't stress when you're getting pimped. You're gonna get pimped. You're gonna get asked questions that you don't know the answers to. And even the residents don't know the answers to the questions most of the time. I'll tell you, my attendings ask questions. I'm like, what kind of question was that? Like, I don't even know what you're asking. And as a medical student, you're like, damn it, I should have known that. It's like, no, you're here to learn. At least in my experience, especially if you're at University of Arizona, you're here to learn and we're here to teach you. So being pimped, like some of the things I remember the most is when I got questions wrong from med school. I still remember, like, it's almost like a shame that you remember, like, oh shit, I got that question wrong. But you will remember it because you're like in front of everyone. But know your anatomy. Everyone will expect you to know your anatomy. That is the one thing as a fourth year medical student that if you show up to a rotation, the expectation is that you know your anatomy no matter what. We may not expect you to know what type of fracture or how to treat the fracture, but if we're doing surgery and we're doing, say an ankle fracture and we're doing a lateral mal ORIF and someone says, what nerve is right here? And you don't know that nerve, the expectation is that you should have known the nerve. Okay. Anticipate the next steps. So the first day, kind of get the layout. You walk in, you've never been on an ortho rotation before. You have no idea what's going on. The residents are moving like so fast because, especially if you're on trauma, you're trying to turn rooms over, you're trying to do a million things. Watch the first day. But once you notice, most things in ortho are very stepwise. So when you go into the operating room, watch how the patient's positioned, help with positioning, throw gloves on. And as soon as you get into the room, how can you help? Help with the Foley, help with like literally anything that you can put your hands on. Never stand in the room and not be doing something. Watch how they prep the patient. So I have like an itch in my nose. Watch how they prep the patient. A lot of places will do like chlorhexidine and alcohol, or however it is that they prep the patient. Watch it so that the next case you can come in and already start opening things, already start having the prep things ready to go so that the resident can say, oh, they're paying attention and they're helping. So like, don't be afraid. I will tell you that most of the time residents will never tell you to stop doing things if you're doing them correctly. The only time they will be like, oh hey, don't worry about that, I'll do that part or this. But like, it'd much rather be that than if I have to tell a medical student that they need to do something. I usually don't even bother and I just let them kind of do whatever they're doing. But if they start doing things, I usually let them ride. I'm like, okay, like they'll figure it out. I trust them. Like they've watched it, they've seen it. If they have questions, like don't be scared to ask either. Write down what you need. So you're going to take call and you're going to be expected that if you have a distal radius fracture that I say, or actually most residents may not ask, but like as a medical student, hey, I'm going to go down and get an H&P and start setting up the splint stuff. So you have two things. You can ask them, hey, what do you want for your splint? Or if you've seen it before, hey, I'm going to go get an H&P. I'll have the splint stuff in the C-arm in the room. I'll tell you right now, if you do that as a medical student, you're already going to be, everyone's going to be extremely impressed. Um, have everything bedside, have everything you need, and write down what, if you've seen a procedure, write it down so that next time you can be like, oh yeah, no, hey, I already have all the I&D stuff in the room. Hey, I already have the consent. I already had, basically have everything ready so that it shows that you, one, paid attention, two, are prepared, and three, that you're like self-sufficient. Because as an intern, no one's holding your hand. You're gonna just go and you're probably gonna drown for a little bit until you make your way back up. But if you can learn all this stuff as a medical student, your intern year is going to be so much easier. And I think a lot of people are nervous, like, oh, I don't want to get the wrong things, or I don't know what to get. Figure it out. Because if you can figure it out, it shows that you're going to be such a good intern and such a good resident, because that's what residency is just figuring it out. Most of the attendings have no idea what we're doing down in the emergency room. They have no idea where to even get splint stuff. They have no idea the logistics of how things get done, how to get a traction, how to do this. So like you're gonna have to figure it out when you're a resident. So if you can, as a medical student, oh hey, I found lidocaine, or hey, they need a different bed for traction. I already talked to the nurses. It's those simple things that you're capable of doing that show that you are going to be prepared and ready for to be an intern. Okay, what do you always have with you no matter what? Have a pair of shears. If a medical student shows up without shears on an ortho rotation, you that's just extremely sad. So if you take anything from this in one day and you don't have shears, be like, damn it, Amber told me to have shears. Have two pens on you because your resident's probably going to steal your pen. Um, Other things. Oh, so I would carry around like a bag, and I'm not saying you have to do this, but I will say, like, when I was on my rotations, I got a lot of compliments on it. I carried around this like little drawstring backpack, and I would go into like the supply closet and I would put a bunch of shit in there, and I would carry it around all day. And then they'd be like, oh man, like on morning rounds, they'd be like, oh man, I forgot my marker. And be like, oh yeah, here's a skin marker to mark the patient. Or man, like I wish I just had some gauze. I'm like, oh, here's some gauze. I have it in my backpack. Oh, I have syringe, needles, lidocaine. Like I was like a walking supply room. And even as an intern, I did it too because I was always running around. But do anything you can try to do to help out. Have things ready because, like, if your service is busy and taking 5 minutes to go to the supply room to get those things can like add up. Um, Always have these three books with you. I personally did not use Pocket Pen, but I've heard great things about it. It came out after I was in residency, but orthopedic, so netters, carry that around with you all the time. Just read it, memorize it. All of the questions that you will get asked on your rotations will come from this book. Handbook of Fractures is very big and thick, and you definitely don't have to know it all. But if you do get basic fractures that you continue to see over and over again, like, femoral neck fractures, intertroch fractures, tibial plateaus, anything that has a classification that predicts surgery. So there's 1,000 classification systems. The big ones that we care about are ones that affect whether or not we can come up with a surgical plan based off of the classification. So those three books are great books to have, especially since everything is always done on our phone. So it looks, at least you can look like you're reading something. Most of the time, you're going to be looking stuff up on ortho bullets and you're going to be on your phone or if you have an iPad or something. But if you're like with an attending, it's better to just pull out your book and show that you're reading a book instead of like, I have no idea if you're like on your phone looking up ortho bullets or if you're like on Instagram. Most of the time you'll probably be on ortho bullets, but it's good to just have a book, and then that way they bring it into the OR, bringing it kind of everywhere with you. Get there early, get numbers. I don't know if any of you have rotated through or what it was like, but if you have like a 30-year rotation or not, but getting numbers in the morning is always like a time constraint. So if you can help, the resident get numbers, that's always really helpful. If you have access to a list, find out who needs dressing changes. So they'll usually say, like, our list will be like, okay, in 3 days or whatever, it'll have the actual date, but like say on 5/27, dressing change of the ankle. So I know that this patient is going to need a dressing change. So one of two things. I can either go in the morning, take down all the dressings, take a picture, and then be like, hey, I already went now, and like have all the stuff ready to so that the resident can go see the wound and then just dress it. Um, or just wait for rounds, but have everything that they need. Like go up there, see what the patient has on their dressing, and then put everything in the room so that the dressing change can be done. Like, oh, don't worry, I already have everything in the room. Like you'll be so surprised how helpful stuff like this is as a resident. Okay.
You
And the
clarify what
OR,
get numbers means? Sorry.
sorry. Oh yeah, yeah, of course. Like I said, I don't know like where you if you guys have done rotations or not. So get numbers is basically in the morning as an ortho resident, we get labs for everyone going to the OR. So normally it's not like medicine labs where you're looking at like every little detailed lab. Normally, at least for us, we get 3 labs that we write down, and it's white blood cell count, hemoglobin, and platelets. And those are the things we care about. Because they can't go to the OR if they need a blood transfusion, or we need to either figure out if they need blood, white blood cell count to see if, if we have an infection patient, and then platelets, obviously, for going to the OR if they can, if they have enough platelets in there. And then INR is another big one. So those are like the 4 major labs. If they're obviously are diabetic or they have like other like kidney issues or something, maybe we'll look into something else. But normally every patient gets those numbers so that we can follow up on things. Good question. Introduce yourself to everyone in the operating room. Don't be the medical student who goes in and then leaves and then no one knows who you are. Like it will be a waste of your rotation. So go in, be nice to the staff, be nice to the nurse circulators. I don't know why. Some of the places I rotated at, the nurse circulators, I swear, are like out to get medical students. No clue why. Just kill them with kindness. I promise it'll be better. If you have a case, like bring in papers, have questions, show that you're interested, but like don't ask questions that you know the answer to, that you want to look good. Like we can tell. Like be inquisitive, ask good questions, like that you've noticed that like came up to you in the middle of the case. Let the resident know when the patient's in the OR. That's huge. If like the resident's out doing other things and you can text them and be like, oh, hey, just rolled back with the patient. That'll be super helpful. Offer to prep the patient, kind of things that have sterile gloves ready so that you can hold a leg for the nurse. Practice suturing outside of the OR. I don't know, at us, like I expect a medical student to be closing most of the wounds when you're rotating with us. And I think it's pretty standard across the board. I remember closing as a medical student also. This is like extra, but I used to do stuff like go get the stretcher, bring it back into the OR, help remove the drapes, transfer the patient, pick up trash, kind of tie the bags, watch the patient pack you, like just be helpful. See what the resident's doing and then take one of those steps from them or a few of those steps from them. Take as much call as possible. Likely you'll be given a call schedule, but if there's extra call, take it. I promise you, like it's exhausting and you're tired and you're like, oh my God, I've never worked this many hours in my life. How am I ever going to be an orthopedic resident? I think the longest shift I ever worked was as a medical student. So it kind of gets better. I don't know. But take as much call because this will help you learn. At the end of the day, yes, you're trying to get a job at wherever you're rotating, but at the same time, you're preparing to be an intern. So this is the time for you to make mistakes. This is the time for you to learn and watch while someone is there to help you. Because as the intern, a lot of times you're just like off seeing consults and you have no help. So learn now. Have consents on you. Yeah, because call is usually one-on-one with the resident also, which is like you get to ask them questions about the program. You get to ask them like questions in general that you wouldn't feel comfortable asking in like front of a whole group. Know the supply rooms, know where they're at, know the codes to them, figure out how to get access if you can't get access. And if it's impossible to get access, be like, tell your resident, hey, let me grab your badge. I'm gonna go and get all the stuff at the supply room. I'll meet you here. We already talked about write down notes, elective rotations, because all that's kind of for trauma. Be early to the OR, be early to clinic, never be late to anything. I think like we've talked at my program, like if someone's late, they're kind of out of it, out of the game there. Have a diagnosis and a treatment plan. And so it doesn't matter if you're wrong, just basically come up with something. So say you're in hand clinic and you think it's carpal tunnel, and you're like, okay, like I saw this patient, I think it's carpal tunnel, even though like it's probably not, whatever. Just come up like what you want to do with it. Because they'd rather see you trying to come up with something than be like, saw a patient, I don't really know, and I don't, can you help me? Like, no, just come with a plan. I can't tell you how many times I go and see my attending, even as a third year resident. I'm like, oh, here's my plan. That's it. And they're like, no, we're not doing that. So don't worry, it happens to all of us, but try to come up with something. Read about, so clinic is where you probably will learn the most because you have time in between patients to look things up and look up papers. Okay, resident on call. We already kind of talked about this. Oh, you can help write consult notes. Just be helpful. Watch and do. Watch and do. Like if you see something, do it again. But also like first day, if you want to go for it, trust me. This is kind of like above this talk, but I figured I put it in here because you may get questions. So there's different types of fracture healing. That's kind of, I think, confusing to understand if you've never heard it before. So if you've never heard any of this stuff and you're like, oh my God, I don't know. And like, how do I learn this? Don't stress out. This is like things that you learn over time as an orthopedic resident, that I'm basically just giving you the words so that when you hear them in the operating room or you hear them, the residents talk about it or the attendings talk about it, you're like, oh, I've heard that before. Now I can learn more about it. So you have primary and secondary bone healing. And so no callus is seen on primary bone healing. Basically, you want a perfect reduction. So you want the bones to be perfectly lined up so that there's no movement and no callus forms at that site and the bones kind of just heal back together. Versus secondary bone healing, there's a big callus. So if you've ever seen like a femur fracture and we fix it with a nail, you typically see like a whole bunch of callus around it. That's secondary bone healing. And if you've ever seen like a tibial plateau, we work so hard to get all those little pieces together because at the joint line, you can imagine that if you have a bunch of callus that's forming at the joint line, the joint isn't going to move as smoothly anymore. So that's kind of the purpose of whether or not we want primary versus secondary. This is kind of the same thing. Absolute stability versus relative stability. So which mode of stability leads to healing with callus formation is relative. It does not have to be perfect reduction to fix a femur. It will build a bunch of callus. It's a strong bone. Versus if I want something like in a joint space, I want like a proximal humerus or a tibial plateau or a pilon. I want absolute stability. I want a perfect reduction because I do not want the bones to be moving. Because if callus forms in that area, I'm going to get post-traumatic arthritis much earlier. This is kind of talking about, length, alignment, rotation is the answer to every question that you will get asked about what is the goal of this surgery? And it's to restore length, alignment, rotation. Length, alignment, rotation. That is orthopedics right there. Length, alignment, rotation. Repeat it 1,000 times in your head. You'll hear it 1,000 times. We kind of already talked about this. Okay, you're gonna learn about different techniques and different plates, and that's all way above what you need to know as a medical student. Again, this is just so that you have heard the words because I don't think anyone really, I didn't know any of this going in. I was like, oh my God, lag screw, what? So basically, there's different types of like fracture patterns and treatment. So lag screws essentially are absolute stability. See this line? We want this perfectly lined up. So if you ever see someone put in like a diagonal screw, usually it happens like in the forearm or the fibula. That gives us rotational stability, but no like bending stability. So what it does is essentially there's two ways of lag screws. So you can lag by design or by technique. So this is by design. So if you look at a screw, there's different ways to talk about a screw. So the pitch is basically the distance between each, I don't know really what they call that, but the pitch is the distance between these two. And then you have the length of your screw and then the screw height. And then you have your screw diameter and then your overall diameter. But for lag screws, essentially, this is by design, meaning that they're are threads. That's the word I wanted. There are threads at the distal part and no threads at the proximal part towards the head. So it engages into the fracture. And what it does is it pulls this piece, because it's engaged, but not engaged here, pulls this piece closer and it compresses it and squeezes it together. So this is a lag by design, meaning it's already set up for us. Most people will do lag by technique. So meaning they use the same size drill for the diameter of the screw so that the threads don't actually engage, and you only drill to the fracture line. And then past the fracture line, I use a smaller drill so that the threads can engage and pull it back. So there's two different types. And again, this is like this is not to go into detail. It's just so that you've heard it before. And when it comes up, you kind of know the resources to go to. So bridge plating, if you see a lot of comminution, guess bridge plating. Buttress anti-glide plating, that's usually in the area of joint spaces. Okay, x-rays. You're going to be asked to read x-rays. When you look at a fracture, so this would be like AP, so I would describe what you see in the least amount of words possible. So as a medical student, even as an intern, like, do not get big into classifications or what you think the classification is, because chances are once you say, I think this tibial plateau is a big one, I think this is Schatzker too. And then someone's going to say, all right, give us the whole classification for Schatzker and like, why do you think it's this? And then you've now just like bought yourself a hole instead of saying, I think this is, tibial plateau fracture with a lateral split. Boom. And depression. Boom. Like, okay, good. So what I would describe here, AP. So you always start with what image you're looking at. So AP of the bone, AP of a clavicle demonstrates comminuted midshaft fracture. Boom. Easy. Most clavicle fractures go into a sling. Same thing here. AP, but we'll talk about this one first. AP of tibia shows a segmental tibial shaft fracture and fibular fracture. Simple. The one on the left, I'm more worried about because I'm concerned for compartment syndrome. So know what compartment syndrome is, know it's an emergency, know how to measure it, know what it means if someone has compartment syndrome. And then on the right, AP and lateral you could say an ankle demonstrates a spiral distal 1/3 tibial shaft fracture or metaphyseal, diaphyseal, whatever you want to call it. So just use your words: metaphyseal, diaphyseal, proximal third, mid shaft. It depends. Sometimes people don't like the word shaft, so you can say diaphyseal. Big thing. So this is intertrochanteric. So AP left intertrochanteric femur fracture. Know the difference between what a stable intertroch is and an unstable intertroch. If you go through 4 rotations and no one asks you that question, I will be absolutely shocked. I will put all the money I have in my bank account, which is not a lot, that you will get asked that question. AP of the hip demonstrates a right hip dislocation. Hard to say, like, I would assume that it would be posterior, but I would say, like, if you want to really get into it, like, oh, maybe a lateral, or what the position of the patient is. Okay, you're going to do great. Be a team player. Do not be annoying. Find the fine line of like being helpful, but also not annoying the entire team, being like, oh, what do you want me to do? What do you want me to do? Can I do this? Can I do that? Like, just, that's why it's easier to just like figure out what you need to do and just go do it. And then if you have any questions, or you are starting a rotation and you want to just know something quick, like, anyone can totally email me, text me. If I don't respond in like a day or two, just repeat. I will eventually respond. I'm just like terrible with my phone. And residency is fun. These are some of me and my co-residents. I love them so much. Oh yeah, these are like my views only, nothing to do with U of A, like having me do this at all. Yeah, just be cool. It's gonna be fun. You guys are gonna have so much fun. So go ahead, questions. No dumb ones. There's no such thing. So ask whatever you want to ask.
All right, there is one in the chat. Thank you so much for like this talk also. It's already been leaps and bounds of help. But Rachel Thompson asked, how many away rotations did you do, and did you do any research?
Yeah, good question. So I am unlucky in a sense that I was a COVID student. So as a DO, I think, are most people on here DOs? Is that like the consensus? Okay. So I can give like a little bit of DO advice here. I only did 3 rotations. One of them was at an allopathic institution, and then 2 of them were at traditional DO programs. So those are the only 3 that I could do like in the area because of COVID. And then what was the second question?
Did you do any research?
Oh, research. Yes, I did. I didn't do research until I was on my away rotations, and I asked the residents and got involved with them because at LECOM, there was no research there for ortho. So yeah, it wasn't until I did till my 4th year rotations that I got stuff together.
Okay, Timothy asked, I've heard that the best research an ortho applicant can have is a first author publication in JSES or the JOS. Would you agree?
If you have that, that is awesome. But I would say the best research that you can have is one that you are involved with, that you start, that you work on, and that you do yourself with like a group or whatever, that it becomes essentially your baby. Because that shows that you can start a research project, you can build a team, and you can complete it. Whether that means it's published in, I don't know, all those fancy articles or journals, or if you're first author or not. But I would say the most important ones are the ones that at least I've heard my attendings talk about, and I got complimented on when I was a medical student, was like, oh, I did the IRB for this and I came up with this project on my own. I did all the measurements, I wrote the paper, I did it all. I think that's much more important because it shows that you're actually, you know how to do the research rather than just like, I'll tell you, so many people do research now and they come out with a gazillion publications and then you ask them about it and they don't know shit about the research. So like that means almost nothing to me. So hope that's helpful. But it's more or less to say like, yes, if you have those, wonderful, but if you don't freak out.
Imran asked, is there any specific advice for us that you didn't already mention? He's a rising 3rd year. Also, how did you balance giving your all during rotations while studying for COMATs?
COMATs. Oh, is that like what are
Like the
COMATs?
shelf ones?
Oh, okay. Yeah. Do you still have to take shelf exams?
Mm-hmm. I think so.
Like when you're on ortho?
Um,
Or
So
like,
these,
I guess,
I'm a current 3rd year. Are all of y'all decom students, or is it just like all over?
we're from all over.
Okay, the ortho doesn't have a specific POMAT. It's like just surgery in general.
yeah.
For that. So you don't have like every single rotation doesn't have a COMAT. It's just certain subjects have COMATs, and then each of your schools will tell you which COMATs you're gonna take.
Yeah, so I think that's more of a 3rd year thing. In 4th year, when you're doing your away rotations, you don't have COMATs anymore. You're typically like, it's usually like electives or whatever that you're using, that you pretty much finish most of them unless you have a required one in 4th year, but you're pretty much like done with those by 4th year. So like, and if you're still in 3rd year, I would focus on those and doing well on those and like doing well on your current rotations. And then once you get to 4th year, really focus on how to be successful as like an ortho rotator.
Perfect. And thank you, Rachel, for help clarifying the COMAT situation. Still learning. Do you have any advice for DOs applying to MD dominant residency programs?
Yes. I think in general, everyone always asks me because I was actually the first DO at my program, still the only DO at my program. I think what set me apart was not my application, it was my letters of recommendation. I think unfortunately, some of the DO programs are not like well known in the academic world. So when you get letters from, community hospital DOs, they're not always well known, and orthopedics is kind of a small community. So if you rotate at an allopathic institution or even like some of the bigger DO programs that have chairs and that have like well known like they're in the academic world, because there are a bunch of DO programs that also have that, is getting letters of recommendation from them. So getting letters that if their name is seen, that someone will know them. Because if it's just from like your community hospital that you doesn't even have residents or anything, it's hard to kind of, as a chair or program director, use that in a way. But most of the time, if it's coming from an allopathic place, like a bunch of my letter writers, I would go on interviews and they'd be like, oh, he was my fellowship mentor, he was my this or that. So it's really all about who you know. So get good letters of recommendations from well-known people would be my advice. And I think I found good mentors, find good mentor that can like make calls for you. I think that's really what set my application aside. Other than that, I was like a normal average applicant.
And to piggyback off of letters of recommendation, how would you suggest we attempt to ask for them on rotations?
Yeah, I usually at the beginning of rotations would kind of set precedent. If I had an idea of who I wanted to write my letter, I would like ask them, hey, do you mind if I meet with you before the rotation starts, and say, hey, or send them an email or something like, hey, I'm coming on, I'm hoping to really do well on this rotation. And by the end of it, if you feel like I've succeeded, would you be willing to write me a letter of recommendation? That's one way of doing it. Or, because then that way they can like pay more attention to the fact of what you're doing. If you ask them after, sometimes they're like, well, I didn't really work with you that much, or like I wasn't really like paying attention. But if you're very specific about the goals that you want, I think it's easier for them to say, okay, that I know the student's looking for a letter of rec, let me pay attention so that I can give them a good one. Because most of the time they're going to say no if they can't write you a good letter. They want to write you something good. And if they can make it even better by knowing that they're going to write you a letter, it could be helpful.
And how much time do you normally give them to write it?
Yeah, it's hard when you're doing an away rotation and you're only with them for 2 weeks and they're like, so usually, I mean, if you're rotating, it depends when the application is due, right? If you're doing the rotation in July, they have plenty of time to do it. They're doing it you're rotating in September and your application is due, then I would definitely recommend telling them from the beginning, hey, I'm going to be looking for a letter of recommendation from you, and the application's due whenever.
Thank you. Any advice on being a female navigating this male-dominated scene?
Yeah, that's a question. I will say hopefully it's gotten better, and will continue to get better. Luckily for me, my program's almost 50% female. So we kind of dominate, even though we're not quite 50%, you can feel our energy. And luckily the males that we have in our program are like so supportive of us, but you will rotate at a place if you end up there. Most programs aren't like this anymore, but there was one program in particular that I rotated at and I was like, yeah, I don't think this is the one for me, because I did feel that. So I don't really know how to navigate it except for the fact of just always be yourself. If you feel uncomfortable, there is never an issue or a problem of you saying, okay, this isn't the place for me, or I feel uncomfortable. I don't think that, it's hard because you're like a medical student and I don't want retaliation and I don't want my name to be, talked about. But at the same time, that we need to stop all of that from happening in general. I think most places now, if things are said, it's not accepted and someone will speak up about it. So hopefully you don't have to go through it. Because most of the men have kind of smarten up and realize they can't say the things that they used to say. And hopefully you have like a strong female that will speak up and say, don't say I think it's happened to me before in the past. And it gets easier as a resident because you're like, don't say that. That's ridiculous. And a lot of times they'll be like, oh, I didn't mean that. And you're like, okay. And they'll apologize. And it's really just like an accident. I've never had anyone be like, don't ever do that in front of anyone again or anything like that. But you will experience it. It's just how you really want to respond to it. Just do what's best for you. That's really my only advice. And you deserve to be in every single room that you were in. A lot of times, like I was just at a sports conference or a course, and it was 40 residents, and only 2 of them were females. It was me and my co-resident. So we're in a room of all males. And I was like, wow. But when I went to the trauma conference, it was like totally mixed, and there was like way more females. So it's just hit or miss. Hopefully that answered your question. And if you need help, find a mentor, reach out to someone. Anyone is always free to reach out to me. I have a wonderful mentor, female attending at my program. I'm happy to get you in contact with people that maybe are at that program or close by, or if you have a scenario and you're like, I really just want to talk to someone about it and get their opinion, like you guys have my phone number and my email. I'm happy to help. Not that I have all the answers, but we'll try.
Thank you. Any general advice on how to go about the social opportunities that medical students will have during audition rotations?
Yeah, be cool, be yourself. I know it's like a stressful, like, do I drink? Do I not drink? Definitely don't drink too much, but it's totally okay to have a beer if you drink. And if you don't drink, also stand to that. Hey, no, I don't. No one's ever gonna be like, oh, that person doesn't drink. Like, no one cares about that. But I would recommend going, even if you don't drink and you don't really go to bars. I would recommend going though, because that's the time where you get to talk to the residents and you get to socialize with them. So it is important. I was talking to a Muslim female recently who's a resident elsewhere, and she was like, sometimes I don't go to the socials because I don't drink. And one of our like attending mentors was like, you should start going to them, like to get known for fellowship and stuff like that. So I think go to it. And if it really makes, like, if it's at someplace ridiculous, I don't think they can do it anymore, but there was like in the past, like strip clubs or stuff like that, definitely don't go. But most of the time it's at like a brewery where there's also food, or so just go, don't drink, still have fun. So step out of your comfort zone a little bit.
Okay, Emily asks, how much do student orgs, research step scores, etc., really play into matching? I've heard that that those are becoming less favorable and that audition rotations can outrule all of these. Is that truly the case?
It can be the case, yes. If you kill your away rotation, and because the residents most of the time don't know your numbers, don't know any of that stuff, and they come in and they're like, we need this student at our program, we have to, unless it is like you failed and you are like just something crazy, you've been arrested 10 times and all that. Most of the time they'll take your application and at least take a look at it. I think scores are going out of way because there is no score anymore. Research is big. It depends what program. It all depends on what kind of program you want to go to also. If it's a research heavy program and you have no research, it's going to look rough. If you're going to like not a heavy research program and really want to get your hands dirty and operate, that's usually where you can kind of stand out from those things if you have a few bad or like not the highest levels of those.
Does doing a 2-week rotation dampen your chance at all, as opposed to a 4-week?
It depends. So I don't think it'll dampen it, but I will say we've had people come for like a week or 2 weeks, and we're like, do they not like us enough to like give us a 4-week rotation? But sometimes it's just how your schedule is, and that's how it works. And we also understand that part. But if we know that someone's done 6 rotations and then they only give us a week, we're like, okay, well, clearly we're not like that high on their list. They're really just trying to get more rotations in. And again, this is all just like personal. It could be different. 5 other residents may have different opinions.
How often do people match at a program at which they did not audition?
Don't have an answer to that, but I did not audition at my program. So
So you mentioned the emphasis that medical students are usually the ones closing and they'll be expected to show our suture skills. Are there resources that you leaned on or you used that really helped prepare you?
everything is online, just YouTube. Just like Google simple suture stuff. There's stuff on Amazon you can order, or like you guys are in the hospital, just like go and take hemostats or something that you can practice with at the hospital. Um, and when you're on your other rotations, like your surgery rotation, or if you're in the ED, like offer to practice there too.
I've heard recommendations that you should wait till 4th year to do audition rotations at programs you really desire so that you're more knowledgeable. Would you recommend this or more so recommend doing a rotation both 3rd and 4th year if possible?
If you have a home program and you can do it 3rd year, no away rotation will let you do it 3rd year. So we won't accept 3rd years. And most programs will not accept 3rd years because of that reason. The reason is that you should be, it's called a sub-I because you're the sub intern. And as a 3rd year, that's not the expectation. So I think it can actually do more harm than good if you're rotating at a place where you want to match at and you're a 3rd year, because you'll be held to the same standards as the 4th years that are surrounded by you that are coming in. And like we always say at the beginning of the year, comparing the first month versus the last month of rotators, like we try to make it even, but it's like a clear distinction of like the end they have rotated before, they have done this before, and at the beginning they're like trying to figure stuff out. So if you can do one at home and learn at home, do that 3rd year, but otherwise I wouldn't go anywhere else for it unless like you don't have a program or something.
Do you have any advice on going about starting a research project like you mentioned earlier?
Find a mentor. Find a mentor. Find a mentor. Find someone that can help you. And whether that be a resident or an attending, like that can hold you accountable, that will have meetings with you, that you can ask questions to, that has published research before.
All right, the chat's blowing up. Good job, guys. Please keep it up. How important is geography in applying? For instance, Timothy's from Georgia and has never been to Arizona. Does that decrease the odds of matching there, all other things being equal?
I don't think so. I think that if you match at or you pick places that you truly want to go to, I don't think it will matter.
So Chase asked, Ream Ortho's page just dropped and they're accepting applicants. Oh, sorry. That is not a question.
Not a question,
Um,
just sharing info. Sorry.
Hey, that's what the chat's for as well. From your experience of, having medical students rotate with you, were there any standouts as far as do's and don'ts that, you've had?
Yeah, so basically, don't be late. It's just like kind of the base. Don't leave until like it's time to go. Don't like get a snack in the middle of the case. Or like in between cases if we're like running back and forth from different rooms. But the big ones are like definitely don't be late. Definitely get there early.
What OR shoes do you recommend?
Ooh, so this I someone bought me as a gift those like fancy calzeros, which is like the Italian, they look really cool. But my feet hated them and I got plantar fasciitis and I couldn't figure out why I got plantar fasciitis, and I had it for 2 years and then I stopped wearing them and it went away. So I'm blaming the Calzeros, but they're real cool. And if you can wear them, they're really nice. Now I just wear Danskos. But when I was an intern, when I was a med student, I actually, these are the sneakers I wore because like most of the time I was running around. So like get something comfortable that you can literally stand there for 15 hours. Anything else?
See, it looks like we're up to date in the chat. Oh, there's one that just came in. Would you recommend shadowing during the summer after first year of medical school or other things to do after first year?
Yeah. Are you a first year medical student? Whoever asked that question?
Yes.
Okay. Yes, absolutely. I love when first years come and ask me questions. We have them come. Typically we will get them into the OR, but also we'll send them with the intern to like hang out. Definitely, if you can, go to grand rounds, get yourself known. Those are all good things to start doing as a first year. I don't think it's ever too early to get involved.
Is there any advice on when we're asked, tell us about yourself?
Oh God. I don't know. Just be yourself. Don't be weird. If you think you have something weird, like you'll be surprised like what people will respond with, and you're like, maybe like you could tell us something different. But definitely have it in your head because you're gonna get asked that a million times in interviews. Usually people want to know what like you're interested in and like what makes you you. So don't just be like, hi, I'm Amber and this or that. Like find something that makes you like I do CrossFit. Everyone that knows me knows I do CrossFit. And it comes up everywhere, every time, and it's something that I love to talk about. So something that you love to talk about that they can ask you questions about is really the opening to it, so that you can have a normal conversation.
Okay. So yesterday, a program director said personal statements don't matter so much for bigger programs because they are very cliche. What is your opinion on that?
Don't really have much of an opinion. So I'm on the interview committee for my program, and we all read personal statements and definitely have a view of how, not necessarily like I don't care about the grammar, how it's written, but mostly I want to know, it's your chance to like tell me about you. And it's usually everyone has really, really cool stories. So for me, it's really cool to read, but I don't know how anyone else feels about that. You're gonna get advice from 1,000 different people, and it'll be conflicting in some ways, in other ways we'll all agree. But like at the end of the day, just do what you think is best. And how like do things that stand within your line of the goals that you want. So if someone tells you like, oh, I wouldn't care about my personal statement, but you're like, you know what? Like, I really want my personal statement to be good. And I want when people read it that like they know I put time into it, then take time and write a really good personal statement that like you're proud of.
All right, Emily asked, I've heard that as a DO, it's not recommended to attempt rotating / applying to MD programs. I understand that your situation's been different. Can you share more of your thoughts on this?
Yeah, I can't tell you how many people told me one, I wasn't going to match into orthopedics, forget match into orthopedics at an allopathic program. So don't listen to them. Do whatever you want to do and go shine wherever it is that you are going to. Yeah, there's historic programs that like are never going to take a DO. Don't go there. But there's plenty of programs that like if you want to go and try it out, all I will say is don't put all your eggs in one basket. Is that know that there's a chance that you will not get into an allopathic program and be realistic. But I don't think there's harm in going and rotating with also rotating at DO programs and applying to DO programs. What I will say is never apply to solely MD programs. Just don't do it. Even if your application is top notch and you think you're the best student in the world, don't do it. Apply to both, give the same respect to both. Don't think that one is better than the other, because wherever you go, you're going to be a good orthopedic surgeon and they're going to teach you. And it's really up to you to learn. Take that opportunity. But like, a DO program is, the program I'm at is no better than some of the DO programs. Like, I have friends at DO programs that are doing the same things that I'm doing. So like, if you have that mentality that like, oh, I don't want to go to a DO program because it's not as good, you are wrong and you will likely not match because you have that mentality. But if you want to go to an allopathic program for other reasons, then sure. Like for me, it was really important to go to a place that had a level 1 trauma center. A lot of DO programs didn't have that. Some did. So I was like, okay, those are the ones I want to go to. Those are highly ranked on where I want to go. Because I knew I wanted to go in trauma. So, but you're going to succeed wherever you are.
And how many programs did you apply to?
This was before like the little signaling thing, but I applied to 150 programs. Yeah, lots of programs.
Is there anything that we absolutely must have on our application in order for it to actually be read by a human being?
That's a good question. I like the way you worded that. It's funny. Um, no, just the things that they say are mandatory. Whatever that says, like with a little asterisk, required. Make sure you have those things.
When we go in to do pre-rounds in our own calls, what are must ask and checked in these patients that y'all expect of us?
Yeah, like when you go get an H&P and stuff.
Correct.
Yeah. So big things are, how did they hurt it? When did they hurt it? Have they ever had surgery on it before? And then physical exam is important, whether or not motors intact, sensations intact, and pulses. Those are the big things. Like, don't go in there and start asking about what is your full past medical history? When was the last time you got your period? When was the last time you did? You don't have to know all that stuff unless it's pertinent to whatever situation that they're in. But most of the time it's, have you heard this before? When did you hurt it? How did you hurt it? Those are big things. Are they on any blood thinners? Have they ever had cancer before? Those are the things that you care about. Orthopedic interest, like very selective history taking.
And to follow up on that a little bit, are we going to be preparing to take night call, 24-hour call, weekend call?
Yeah, you should be prepared to take night call, weekend call, and 24-hour call. Trust me, it's very daunting, and I never thought that I would be able to do it, but I'll tell you, I just do 24s now, like it's nothing. You don't even, when you're in the hospital, it's like whatever. The lights are so bright and there's moving and you're like running around and you're like, oh shit, 24 hours just went by. God, you don't get tired till you go home.
Let's see. How important do you think GPA is regarding to applying to residency? Emma's heard that it's becoming less important due to many schools going past fail, and wondering what your opinion is.
Yeah, I agree, but I don't know. I can't say for sure, so I don't want to give you any like advice of, well, she said that my GPA was this, so I don't know. Don't have an answer for that one. Just do as well as you can.
And when did you know for sure that you wanted to do ortho trauma?
So I was between trauma and spine until about a month ago. And then we had a bunch of spine complications, and I was like, and the cases were like, I was starting to get hungry in the middle of the cases because some of them were like 9 hours, and I was like, I need to eat. So that's when I decided on trauma.
All right. Since signaling, since the signaling change, How many applications do you recommend to send out? Collins heard 30 because that equates to the number of signals.
Yeah, so I have heard that also. I think most programs are not interviewing you if you did not signal them because they have plenty of applicants who did signal them. So, I mean, I don't think there's harm in doing more, but I do know that most places probably will not interview you if you don't send out the signal. And if you didn't rotate, but that would be weird to rotate and then not signal or whatever. And some places, if you do rotate, I think we tell our rotators, like, you may not have to signal us because you rotated here, so you don't waste a signal. So depends. Just be mindful of that also.
And Chase recalls that you said 3 auditions. If you're comfortable, can you share how many interviews you had?
Yeah. So I applied to 150 whatever programs, and I got 22 interviews. 11 of them were allopathic and 11 of them were DO programs. So they were very much mixed. And I would say probably about 50% of the allopathic ones, comments were made about that was the first time they've ever even interviewed a DO. So hopefully things are changing. I don't know how it's going to be with pass fail or whatever, but I don't think because you're a DO, you need to put yourself in this box of, I can't do this. You totally can. And people will tell you that you can't, but I can't. Literally, like, the dean of my med school was like, you shouldn't even apply ortho. You should go family med. And I was like, what? Why? And he was like, well, it's really hard. And I was like, okay, so was this school. So just work hard and you will succeed, I promise.
All right, I just got one last question, if you have time. Timothy asks, if you already know you're interested in a particular orthopedic subspecialty, would you mention that in your application? For example, I got diagnosed with cancer a couple of years ago, and now I'm interested in orthopedic oncology. Should I mention that in my personal statement?
First off, thanks for sharing. I'm sorry that that happened. I think it's totally fine to mention that and be able to say, like, I went through this experience and this is what I now strive to either research, or I think it's totally fine to talk about that if that's what's important to you. And that's the reason why you're going into orthopedics. Like I said, whatever it is that drives you or makes you want to be an orthopedic surgeon, use it. Except I will give one piece of advice. If you tore your ACL and you had an orthopedic surgeon and that's why you want to be an orthopedic surgeon, don't say that because it's like you and 900 other people. So, but I think that's totally reasonable. It's something obviously had probably a huge impact on your life. So I think it's, kind of a good story to share.
Yeah, Timothy, thank you for sharing. I want to read that personal statement now. But we do not want to take any more of your time today, Amber. We cannot thank you enough for all this incredible insight and giving us a leg up when auditions come around. Perfect. Yeah, if anyone wants to
Yeah, like I
email
said,
SDIO for the
exactly.
contact information, we can do that. But any closing remarks?
No, thank you guys for coming. I wish you guys the best of luck. You're all gonna do so great. Work hard, be cool. I promise that will get you much further than if you can answer all the questions right. And feel free to text me, email me. Like I said, I am the worst. Even my family like has to triple text me because I'm either sleeping at the gym or in the OR. So, yeah, good luck. If you end up wanting to come see us here, more than welcome, reach out. Or if you already know you're coming here, or if you have questions about DO programs, I have friends all over the place. So definitely ask me. I can get you in contact with someone, I'm sure.
Thank you.
Yeah, you're so welcome. Good luck, everyone.